Dear leaders, dear supervisors, dear colleagues, welcome to the 12-month progress report. In the next few minutes, I would like to introduce my progress. I've got two projects dealing with hemodynamic instability and gastrointestinal bleeding. And if I want to put one title for these two projects, it would be the epidemiology and management of hemodynamically unstable gastrointestinal bleeders. I'm Mahmoud Obeidat. I'm a medical doctor and PhD student at the Center for Translational Medicine at Semmelweis University. On this slide, you can see my productive team. And since I'm dealing with my two projects about hemodynamic instability, of course, my vision would be to improve care and management for those patients and to come up with a guideline-based treatment for them. And the mission, we have to prove statistically the high proportion of those patients and the variability in the different treatment methods. These are my specific goals. My first project assessing the exact proportion of those patients, and the second project targeting the healthcare providers by doing a European survey about the pre-endoscopic assessment for those patients. And now I'm going to talk in details about the first project. It's going to be a systematic review and meta-analysis. The title of my manuscript is 1 in 4 patients with gastrointestinal bleeding develops shock or hemodynamic instability. But before we end up with this title, there was a really long journey behind that. The incidence of GI bleeding is unacceptably increasing. It's 100 per 100,000 population annually with an estimated mortality rate up to 15%. Many studies showed a significant association between hemodynamic instability and unfavorable outcomes like higher mortality rates, rebleeding risk, pre-hospital transfusion, and sedation complications. And even though many studies showed this association, we still don't know the exact proportion of these affected patients. And there was a recent study, a national analysis, showed an inclusive conclusion actually that patients with GI bleeding who develop shock are 10 times at higher risk of mortality than without shock. So the aim is to assess the exact proportion for those patients and specify according to the bleeding source. We used the COCOPOP framework for our clinical question. The condition was hemodynamic instability or shock. The context is gastrointestinal bleeding and population adult patients more than 18 years. We've done the systematic search on 3 main databases using our search key consisting of 2 main concepts. The first concept is gastrointestinal bleeding with different synonyms, and the second part is hemodynamic instability or shock. This is a PRISMA flowchart of the article selection process. We've managed to decrease the number of the initial hits from more than 11,000 hits down to 220 articles eligible for data extraction. Now I'm going to introduce the main results we've got. And before I introduce it, there's a brief orientation how to look at my slides. On the right side, you can see the source of bleeding. We've got a number of articles with unspecific gastrointestinal bleeding. So it includes upper and lower GI bleeding. On the upper part of the first plot, you can see the author and year of publication. The event rate is the number of patients who develop shock or hemodynamic instability, then the source of bleeding, and the proportion and a 95 confidence interval. We've done the subgroup analysis based on 2 points. The first point, whether the patients developed shock or hemodynamic instability, and the second point about the time of assessment, whether they develop it on admission or during hospitalization. At the bottom, you can see the overall effect of the included patients. And in this case, 25% of gastrointestinal bleeders developed shock or hemodynamic instability on admission or during hospital stay. And next to it, you can see the certainty of evidence. In non-variceal bleeders, we've got 22%. And I would like to highlight here that there is a big difference between the shock on admission and shock during hospitalization. 36 of the patients develops shock on admission, while only 7% of them develops it during hospitalization. On variceal bleeding, we've got 25% of the patients were affected, and in colonic diverticular bleeding, 12 patients developed shock or hemodynamic instability, and all the patients were assessed on admission. So in conclusion, 1 in 4 in gastrointestinal bleeding, 1 in 5 in non-variceal bleeding, 1 in 4 in variceal bleeding, and 1 in 8 in colonic diverticular bleeding develops shock or hemodynamic instability. So our strength that this is the first comprehensive overview about hemodynamic instability in gastrointestinal bleeding based on the bleeding source. We've included a large number of articles, more than 200 articles, with more than 6 million patient data included. And subgroup analysis been the time of assessment, whether on admission or during hospitalization, adds a more inclusive approach to this field. The limitation of our work that the definition of hemodynamic instability and shock were not exactly the same among the included studies, and we actually lack this definition in 1/3 of the included studies. And mostly we included retrospective observational studies. Implication for practice: increase insight and awareness about hemodynamic instability in gastrointestinal bleeding. Those patients need continuous monitoring and rapid correction of hemodynamics, and careful pre-endoscopic assessment and strong adherence to risk stratification scores. Implication for research: we need to standardize the definition of hemodynamic instability worldwide, and we need to establish a protocol to proactively screen and monitor those patients in the daily routine management. This is the status of my manuscript. We're polishing the last comments from the internal review before we send it to the language editing, and our aimed targeted journal is American Journal of Gastroenterology. My second project, as I mentioned, targeting the healthcare providers, and we are aiming to know their opinion about the pre-endoscopic assessment to manage hemodynamically unstable non-variceal bleeders. So the background about this topic is basically the same as the first project, but I would like to add here that the most recent update of the ESGE guideline stated some gaps and uncertainties regarding the management of hemodynamically unstable patients. There are still gaps about the fluid type and the optimal fluid rate. So the aim is to understand the care and assessment and the management for those patients by doing a survey and filling out a questionnaire. So our hypothesis is that there is a significant variability between the different treatment methods. And we believe it's based on the years of clinical experience and the individual patient factors. And for that, we built a questionnaire containing 3 main sections. The first section, demographics and clinical practice for the doctors, and the second about the definition of hemodynamic instability, and the third section about the stepwise assessment of those patients, and it is subdivided into 3 main sections, but we're going to focus on the pre-endoscopic assessment. Here are some sample questions from our questionnaire. In the demographics and clinical practice section, we're going to ask about the geographic location where the doctors work, how many years they have been in practice, the focus of their specialty, and the number of the estimated patients they treat annually. In the terminology section, we ask about the exact definition of hemodynamic instability. We found variable definitions, especially in the first project. Some authors define it as systolic blood pressure less than 100, some of them heart rate more than 100, and other authors stated systolic blood pressure less than 100 and heart rate more than 100, which was the most common definition actually. But other authors also included syncope, orthostatic hypotension, or signs of organ hypoperfusion. And in the third section, we're going to ask about the pre-endoscopic assessment, some questions about if they use risk stratification scores and what type of fluid they are using for resuscitation. So this is a flow chart about the survey progress. We are establishing a final consensus before we start distribution. This is an overview of my 2 projects with the planned submission date. And before I close my presentation, I'll leave you with this quote from Isaac Newton: "What we know is a drop, what we don't know is an ocean." I thank you for your attention. I am happy to receive and answer your questions.
I have a question regarding your second project. What is your target with the survey? Which country, or it will be worldwide? So what is the...
It's gonna be a European countries. We're gonna it was before, previously it was international, but we found it's a really big challenge, and it was divided into 3 main sections, but we focus on only pre-endoscopic assessment, and it's gonna be about the European countries basically.
Thank you.
I have a question concerning the first study, and what struck me is, well, based on the author names, I didn't find many Chinese studies. So do you have an explanation for, I mean, we usually get a lot of publications from
we do
China.
actually, but I didn't include all my first plots here. We have 2 big ones about peptic ulcer bleeding and lower GI bleeding, and also upper GI bleeding. So we do have Chinese publication for sure.
Right,
Yeah.
okay.